and welcome to BerryDunn's podcast, Healthcare Technology Insights. My name is Dan Vogt, and I'm a principal here with BerryDunn and lead our healthcare technology consulting practice. Healthcare Technology Insights is here to inform, instruct, and energize healthcare leaders. Our podcast includes healthcare professionals from all over the nation and brings together key topics for discussion to have a real impact on the healthcare industry. Speaking about important healthcare leaders, our very special guest today is Alan Weintraub. Alan is a senior manager and colleague of mine at BerryDunn. Alan is a physician by training and career, having earned his MD from University of Michigan, his residency in anesthesiology, and fellowship in cardiovascular anesthesia from Yale University. Alan has 35 years as a practicing anesthesiologist, as well as experience in practice, departmental, and hospital leadership. Prior to joining BerryDunn, Alan was the area vice president for a large national anesthesia corporation overseeing clinical services at ambulatory and office-based facilities. At BerryDunn, he brings his clinical, operational, and technology experience to help our clients in the areas of practice management, medical staff relations, governance, physician onboarding, clinical compensation, workflow design, risk management, and electronic health records. Alan and I have been talking lately about the infusion of technology into clinical workflow, the systematic and challenging physician burnout situations going on, and emerging technologies such as artificial intelligence. I'm looking forward to Alan sharing his insights with you in this episode and bringing some perspective from that of a physician. Alan, welcome to the program. Thank you so much for joining.
Oh, thank you, Dan, for inviting me. It's always a pleasure to talk to you. And thank you to everyone for listening in today.
So, Alan, you've had a career, as I kind of went through in your bio, that really does have a variety of experiences, from a practicing physician to that in significant leadership roles. Can you just tell our listeners a little bit more about your experiences and what you've learned from them?
Sure. Thanks, Dan. Well, I've had the privilege of serving in many capacities, as you note. My roots really, though, are as a practicing frontline anesthesiologist. I have a specialty in cardiothoracic anesthesia. And over the years, I've been privileged to serve as a clinical practice leader in medical staff leadership, practice management, and in regional leadership. Along the way, all those experiences have given me a broad perspective on medicine as a whole, and I've learned to listen a lot and picked up many skills that simply aren't taught in medical school or in residency training.
It's a good comment, about the blend of technical and some of those soft skills you're sort of alluding to. And the more I think about technology, the more I think it really is the blend of understanding both to be successful. So let's dive into technology a little bit.
Sounds great.
Technology is evolving. It's evolving a lot over the last 30 years, from like the early digitization of radiology and getting rid of films to today, where AI is all the hype and how it's going to impact clinical workflow. Any perspective as you think about your career and the evolution of technology?
Sure, Dan. If you take a broad and long historical perspective, we're talking about constant evolution. And you look at the logarithmic rise in technology in recent years. And that really, in medicine, that rise in technology use has mirrored a technological advance in our society as a whole. I remember seeing those curves talking about use of technology and computer power, and you see the very steep logarithmic rise on a graph. And we've seen that same thing in medicine. You look way back, you have a progression on just the use of the tools available to us as human beings, physical observation and hands-on touch, and what we learned early on in physical diagnosis in medical school. It's called palpation. And and then the use way back of very simple technological devices such as a stethoscope. Well, now today we have highly sophisticated monitoring and diagnostic devices. If you just look at anesthesiology, my specialty, in the 1970s and 1980s, you had this a huge boom in the use of technological adjuncts to be able to safely take care of patients having surgery and anesthesia. And those decades witnessed the use of pulse oximetry and capnography, the measurement of gases inspired and expired or breathed out from the patient. And those technological tools made surgery and anesthesia vastly safer. Well, now, more recently, Dan, we've got just an explosion in diagnostic tools across medicine, witnessed the growth of computed tomography, magnetic resonance imagery. In cardiology, you look at the progression back a couple decades ago was the use of echocardiography, using ultrasound to image the heart. And initially, it was just called biplane, and the use really seeing just being able to look in two different planes. And then it grew to multiplane use. And now there's 3D reconstructions of the images. So it's just exploding. And along with that, EHRs, electronic health records, their use and their capabilities have absolutely exploded. And as a next extension, you mentioned, and subject to this podcast, is the use of AI. And broadly, they're being used in clinical medicine, in healthcare as a broad industry, if you will, not all the time directly related to patient care immediately. And AI tools are being integrated in electronic medical records.
It's interesting. I kind of want to ask a little bit of a follow-up question there, Alan. You mentioned a lot of the technological advances, and many of them early in your description had kind of direct care advances, right? Some of the more advanced diagnostics, some of the better tools for monitoring safety, like that's very much directly aimed at better, faster patient care, higher levels of safety. And then you get to the EHR, which has a blend, right? It has a blend of direct care elements, but then a whole bunch of more administrative and operational components to it. And I don't know, any thoughts you have when you compare some of the advances in the straight up clinical technologies versus sort of this blended EHR technology?
Well, sure. As a physician, and I think here's where physician gripes and complaints and criticisms of EHRs come in, Dan, is that just as you say, there's a lot of components of EHRs that physicians will view as not directly and immediately helping them take care of patients, and view as busy work, and creating more effort, and actually, in some instances, detracting on their ability to just take care and do what needs to be done for the patient. Interestingly, and I'm sure we'll probably get to it, chat a little bit about it in a few moments. Somewhat paradoxically, the use of AI, I'll put forth, can and should be utilized to decrease that amount of extra work and other tasks that sometimes the EHRs demand that physicians perform. I think there are some tools that are coming to decrease that, and I think that's a good thing.
Absolutely. No, it makes sense. And I think we're going to, transition to a little deeper dive on AI, but I'm just, I'm thinking about it a little bit, what you're just sharing. And, it may be, and we'll get to this later in the podcast, You take an image technology that is important to me as a clinician. You mentioned, cardiologists and looking at the image of the heart, and you make it better, right? You just got to make it better, deeper, clearer. I can examine it more thoroughly. It's probably an easier sell or an easier adoption, if you will. You just said, like, you took the tool that I had and now you made it better. You go to an EHR and there's things that don't make the physician job necessarily better today. We need to find a way to do the same thing with EHRs. We need to find a way to say, how do we apply technology and say, you had this thing, now let's make it better for clinical care. And it'll probably be an easier thing to lower the physician gripe factor a little bit.
Absolutely. I think you right on target.
Yeah. So let's dig into AI a little bit, a little bit deeper, because I think there's a lot of hype around AI. I don't think there's a conference or a session I go to now that it isn't a session. It isn't a topic. It isn't a track. There's a lot going on with it. And as I think about AI, as I think about, all the emerging technologies and wearables that are tied into that, I start to think, what does that present? What opportunity is that when we look at it from a clinical and medical perspective? So I'm curious, as you think about it as a physician, what do you see here?
Thanks. First, Dan, I'd like to make the point that we're not talking about AI in the future and looking forward. AI is already here. We're using it every day, I think, in our lives. Hospitals, physicians' offices, healthcare broadly, we're already using it, and it's going to continue to evolve. I saw an interesting statistic, a recent survey of chief financial officers for healthcare institutions responded that 98% were already piloting AI programs in some capacity. And I think in general, as physicians and more broadly, other clinical staff are embracing AI. Some may see it as impersonal and challenging, but I think the view of most is that it's an opportunity and does enhance our capabilities. And I think that that's the way that we should look at it. Here, particularly in the lay public, fears about AI will be replacing clinicians or take over. And that is way, way off in the future. I think we really need to embrace this as an augmentation of our skill set and really, and I think most physicians see it that way. I'd like to, if I can, Dan, to talk briefly about really what AI does and where its capabilities lies on a kind of really a fundamental level. AI really is different than tools in the past in that it enables prediction rather than just statically looking at past data. And I heard a presentation recently, and I'll borrow the speaker's words because I thought they were really good. And the quote was that generative AI enables prediction, and then prediction yields the ability for a prescription, or actually being able to provide and suggest a course of action. And I think that's really where the capability of AI lies in medicine. Not that it's going to do it, it's to provide those tools and that information to enable the clinician, the physician, the nurse, the PA, nurse practitioner, to then critically look at those things and then make a good decision for the patient.
That's a good summary, good foundation, Alan. I think as we think about AI and clinical workflow, similarly, I was at a hospital association meeting and there was a gentleman presenting on AI and talking about some of the examples you hear a lot about, right? Imaging in particular, he focused in on a little bit, and the ability for these computerized systems to both examine the image at a smaller, more incremental level than perhaps the human eye could detect, which we've talked about for a while now, these computerized imaging things. But what it really was getting at too is AI looking at, let's say, a mass on a lung that may be cancerous, but then going in reverse order and training it to would that mass have looked like very early on, and like learning the progression of growth, so that, to your point around predictive leading to prescription, with the quote, we're training models now to say this very minute thing and be predictive to say, I think this could become a problem. Let's intervene earlier. And
That's exactly it. And there's a number of real world examples of that, Dan, where that's going on now. For example, a model created in Europe was looking at EKGs, heart rhythm recordings of patients in the hospital, and it was able to be trained and was able to successfully predict ahead of time which patients would go into a rhythm disturbance called atrial fibrillation. So it able to predict allowed clinicians to intervene ahead of time to take care of that patient. So there's that predictive ability that's going on right now, and we'll see much more of that. There are models in ICUs doing a similar kind of thing, looking at laboratory data, pulling from the electronic record and monitoring devices and patients, looking at historical data, laboratory vital signs, and then predicting which patients are at risk for sepsis, and then allowing the staff to intervene and avoid what can be a very, very serious course of events.
Alan, I may want to take a slight detour here with a follow-up question, just kind of see where this takes us.
Sure.
It's interesting. For years now, when we go into conferences and we talk about the evolution of healthcare and how it needs to improve, there's been a lot of discussion around sort of I'll call it curative medicine. So I have some sort of disease and I'm going to help manage it, whether it's chronic and it's a managed sort of thing, or it's a potential curative opportunity, versus preventative medicine, right? Being out ahead of it, right? And in some of the EHR systems, there have been pretty basic tools for preventive medicine. I'm a diabetic. Have I had my foot screening done? Have I done these sort of elements? We also talk about sort of personalized medicine as we start to map genomics and get much more specific about how to treat me as the individual based on kind of who I am and how I'm made up, right? And if we step back and look at AI, precision medicine, preventative medicine, all these sort of initiatives, are we really getting to a new era of kind of precision preventative medicine, emerging here?
I think so, Dan. And though, I don't claim to be a medical futurist,
Yeah.
but if I can pretend for a moment to be one, I'd say, yeah. I think one of the capabilities of AI is actually to take this unbelievable database that are in various EHRs and pull from patient comments and some patient inputs, previous notes from caregivers, and laboratory data, diagnostic data, and pull all of that and take a look at it, and then look at patterns, and then be seeing patterns, and having been machine trained with good databases, and we should come to the databases on which AI is based, and then be able to present to the clinician, hey, this is what things look like. You might want to think of this, or you might want to plan for this. And these are things that you might want to do to maintain your patient's wellness. Or these are things that may say, hey, there's a high likelihood that this will happen, and suggest a course of action. So I think we're going to see that. And I think that's kind of exciting, in the context that it is an adjunct and providing decision support to the clinician. Because, Dan, I still come back to it. There is no substitute for the human brain, despite this machine learning's capabilities, generative AI. There is no substitute for that doctor-patient relationship that's founded on empathy and trust. And boy, the human brain still has that nuanced thinking that AI and computers just don't have. And I think our challenge is that we've got to leverage that analysis of data that AI provides us with that critical thinking, and eyes on patient and connection to the patient that human beings still have.
Yeah, I think you're right. I really see it as a complement, an augment, a tool set, right? However you want to look at it, not a replacement. I was at a session and they were presenting AI, and I think they had some quote, and I might be butchering it slightly, but kind of the premise was we shouldn't fear that AI is going to replace humans and workers, right? But we should fear that workers who master using AI will replace those who don't. Something to that effect. And I think that speaks highly to the capability that when you take a highly trained person in whatever field that may be, in this case, we're really talking clinicians and physicians, but it could be anything, and you pair them with something that allows them to have data faster, more precise, earlier, with larger data sets, and we'll transition into that in a minute. They're probably going to be even better than they were without it. And
Absolutely.
That's the future, right?
I agree. And Dan, what we haven't touched on, we've been talking quite a bit about really clinical treatment of patients, but I think there's an enormous role, and we're already seeing it, of AI in improving efficiency and helping decision making about allocating resources. We're already seeing AI in scheduling programs to intelligently allocate staff resources and assist with staff scheduling, with resource utilization in terms of booking and scheduling surgical cases in operating rooms, and operating rooms being used as thought of as a physical resource, expensive and in a way scarce resources like robot devices for complex robotic surgical procedures. So that's already here, and I think we're going to see that being used more and more by healthcare facilities.
I think that's a great point. We have focused a bit heavily on the clinical piece of it, but I think a lot about gains for the patient, right? And the operational efficiency opportunities you're describing, I actually think have huge opportunities for the patient, right? Patient access is a problem, right? Trying to get in to see whether it's a primary care whether it's a particular specialty, whether you're in a rural area and you've got, care deserts cropping up. If we just can use technology to suddenly optimize schedules, increase visits, put resources available where they need to be, I have to think there's an opportunity to improve patient access, which is going to be, if I can see my doctor sooner for something that I care deeply about as a patient, I probably be happier and adopting and embracing the technology that comes from it. So,
Uh, Absolutely. And I'm glad you brought that up, Dan, because I think what we'll see is use of AI tools in rather patient screening tools, use in patient triage with exactly that intent to improve access. The reality is that we actually have a physician shortage in this country. There's certainly some care deserts and some areas of high physician density, but looking at a number of studies that have come out projecting primary care physicians nationally and the increasing demand for care with an aging population, we have across multiple specialties a physician shortage. And I think AI will be used increasingly to, extend and expand a physician's capabilities, so that um, and one example, actually, from my specialty, there is a critical shortage of anesthesia providers, anesthesiologists, and nurse anesthetists. And in development, there are early things, tools to really enable an anesthesiologist perhaps to care for more patients uh, uh, at a time, by supervising and development of, not that, anesthesia is going to be given by robots, but in a care team model, which is frequently used with an anesthesiologist immediately and directly supervising nurse anesthetists, the ability to safely care for more patients with command centers and remote monitoring, so that while an anesthesiologist can still be immediately and directly involved, have the tools to be able to uh, uh, manage and care for a couple patients at a time.
I'm picturing what you're describing here in my head a little bit as we're
Yeah,
talking, and and I'm picturing it becoming almost like a potential air traffic control situation, right?
yeah,
We we as consumers of flights get on planes all the time, and we're quite comfortable that
yeah,
there's a command center someplace making sure that all the planes are flying in the right direction and they're paying attention to it and communicating with
yeah.
the crew of each individual
But,
plane. It's not,
but
doesn't seem like a
that's
dissimilar parallel.
well, I think that's a good analogy that you make, and it's being talked about. I think the tools are starting to be there. I've seen actually some demonstrations of some pilots of those. Pardon the pun, but it's already there. And in fact, it's one of the recommendations in a recent American Society of Anesthesiologists article looking at some suggestions for addressing workforce issues. Um, um, but that's a little bit of a digression, I think. I apologize.
That's okay. I mean, part of these podcasts, I think, and what we can bring to listeners is the opportunity to explore topics like AI and to really think about how might this work in the real world, right? I think we could get very technical, but that's not our intention. I think our intention is to help leaders think about what
Yeah,
happens when these things come to them
yeah,
and where might they want to think about
yeah.
opportunities. And I think it's a good segue here for our podcast to think about burnout, right? And that's something I guarantee every client of ours is feeling in some manner. Staffing shortages have been challenging. Physician and clinician burnout is is high, and it's written about. I mean, even the Surgeon General, I believe, made health worker burnout one of the top priorities. Now, that is probably because of the strain that the pandemic put on the entire clinical workforce. But beyond that, I think the day-to-day work that goes into caring for patients and then doing good documentation and dealing with all the administrative and operational tasks you were alluding to earlier is contributing, right? So EHRs and click counts are certainly at least a identified reason, whether they're the full reason or not. There's a number of things I think contributing to physician and clinician burnout, but I'm curious your perspective.
Yeah, well, it is a major issue. In recent survey, up to 60%, if not more of 60% of physicians report symptoms of burnout. And EHRs have been cited as a contributing factor to that burnout. Now, one of the real strengths and roles of AI is to assist with and help out with repetitive, low risk tasks. And to the extent I think that AI can be utilized within those EHRs to minimize that tedious, repetitive, as you referred to, click counts for things, that I think will go at least to alleviating one of the factors associated with clinician burnout. The other thing as a leading cause is just the bureaucratic tasks, charting, paperwork, etc. So I think that AI tools can and should be deployed to help with that. Common theme that we've talked about, Dan, we're already seeing it. So AI is being used in transcription services and dictation, so that rather than typing in everything into an electronic record, the clinician can speak, and these tools learn and get to know that particular clinician, and then with use get better over time to make entering things into a record easier. And I think to the extent that those tools can be deployed and maximized and minimize the repetitive, tedious tasks, and then free up for the physician for really doing the clinical care and utilizing the cognitive skills to make really good decisions for the care of the patient.
I think I'll just call it kind of the hands-free patient experience that's being, promoted heavily right now, I think by most EHR and technology companies right now, seems to, I would think, be quite attractive on the surface if you're a clinician or physician, right? So rather than having to worry about, they talk about the triangle in the EHR best practices. You don't want to have the computer as a barrier between you and the patient, so you can make eye contact and make a more human, centric experience, right? We can stop worrying about that potentially and have ambient listening, right? And you can be having a conversation with the patient, talking to them about what brought them in. It's capturing both the patient's words and information and, what the clinician is suggesting, putting that all together in theory into a note, building an order set based on it, maybe even adding to the problem list based on a identified diagnosis during the discussion. I mean, that seems like something to be very attractive to a physician.
It would, and I think it would be attractive to both physician and the patient, because I've heard a number of patients explain to me, or even my family members describing the appointment and saying, "Oh, well, the doctor seemed really nice, but they were sitting and never looked at me, were sitting looking at the computer screen and typing away. Patients want that contact, and I think most physicians want that also, and feel torn that they have this mandate, if you will, to use the computer and enter things in, and need to then, and are truly cognizant and torn. Hey, I need to connect with my patient, and are kind of then forcing themselves to look up, turn, etc.
Yeah. It's interesting. I'm a change management practitioner, so I think about how humans naturally resist change. It's sort of we're sort of wired that way. I sit on the same spot on the couch every night as my wife sits in the same place too. We're creatures of habit, and change is always a little bit uncomfortable, no matter how good or exciting the change may seem, right? So, I'm curious to think about the patient perspective here for a minute, right? And yes, they don't like the fact that a clinician may not be making eye contact and typing the whole time, right? But now we're entering an era where they're being recorded, where AI is listening this whole time, and healthcare can be very personal, right? We may be sharing probably some of the most personal details of our lives with our physician because we're concerned about something, right? And how is the patient gonna, how do we get past that change adoption piece to say, hey, this session's going to be recorded, but I still want you to share everything I need to know?
Yeah, I think, Dan, you bring up, I think, what will be a thorny issue, because patients are going to need to have assurance and that their information will be safe. I think they need to be comfortable and feel safe in that kind of environment. And collectively, we have absolutely got to make sure that kind of information is secure and kept private.
Mm-hmm. It's going to be a new era, I think, of privacy concerns potentially from the patient when we jump to this level, right? Because someone may be concerned about, I'm just thinking about human reasons, right? What if my family found out, or what if my friends found out? What if my employer found out? Like, if you're dealing with something that would disqualify you from your job, right?
Right. And it's one thing that if there are written notes in a record about something that may be very personal or private, and we worry about an employer finding out. But I think having a recording, whether video or audio, rises to a whole other level, and we have just got to make sure that would be absolutely kept private, and patients would need to feel very comfortable sharing.
It's change, right? It's going to be change, and change comes with those things that get people excited, like, oh, I can make eye contact with my doctor and they spend time with me and they're not just typing. To how do I feel about that AI is listening, right? And we'll have to just work our way through, I think, and educate and work as a team and give confidence that we're serious about privacy and security. So let's bring this thing home, Alan, if that sounds good to you. I think I first off want to just thank you. I think that our audience should find this really helpful, informative, I hope fun, exciting, concerning, all the things we wanted it to be. Our former colleague and now retired grandpa, Danny Burgess, kind of started a tradition when we kicked off this podcast to close with a question. So we're keeping the tradition alive. And the question is this: you have unimaginable amounts of money, okay, to spend on healthcare technology, and you have no regulations that you have to adhere to. So what is your top priority and why?
Good question, Dan. And I have an easy answer for you. And it's really a simple one, because it's not anything hugely fancy or complicated. To deliver great basic care, I'd say we need to invest in and do whatever it takes to have an interoperable, accessible health record with data sharing so that various physicians, other caregivers, et cetera, no matter what institution, can be able to access a complete medical record and all the data that have entered from various points, and be able to use that to take great care of the patient. We haven't had it to date because there's been privacy issues, ownership issues, et cetera. I think we can probably solve those and make sure that patients have a universal, interoperable, accessible health record. And I think that would make a huge difference in taking in quality of care, and also potentially save money. Dan, how often have you perhaps personally or your family member gone to a doctor's office or a healthcare facility and had, let's say, another lab test taken that you said, well, I just had that one at this other place last month. They say, oh, well, we don't have that result. We're going to get our own. Has it happened to you or your family member?
It has, and I'll go even further, Alan. It's a little bit personal, but my mom suffered from dementia and was in a number of different assisted living communities, and we were having trouble kind of getting the physician team to really get a good sense of what was happening with her health. And ultimately what I ended up doing was I went to one community and asked them to print out all of their progress notes. So I got about 6 months of progress notes from one community. And then I went to the other community and got them to print out the next 3 months of progress notes, all on paper, mind you, right? And I brought it into the hospital and I gave it to the physician in charge. And I said, could you please just read this? Because I think you'll finally see the story of what's happening. And they finally did. And we finally figured out, what to do and what the right care plan was. But it wasn't interoperable. It wasn't even electronic. The only way to tie it all together was me to drive around in my car and be a care advocate. So, it is a bit personal for me, but I think you're spot on right.
Right. Well, I'm sorry about your mother, Dan, but I think that your story illustrates the issue perfectly.
Well, Alan, thank you again for coming on the podcast. It's been a lot of fun. You can find our podcast on iTunes, Spotify, SoundCloud, and Google. I'm Dan Vogt, and you've been listening to BerryDunn's Healthcare Technology Insights. Thank you for listening. Be well and stay insightful.